The last case is 70-year-old female with pancreatic duct dilatation. The patient's first presentation was abdominal pain and elevated pancreatic enzymes. CT scan and MRCP showed main pancreatic duct dilatation from the pancreatic body to tail. The patient was scheduled for further workup by EUS and FNA for possible pancreatic head tumor. Operator is Dr. Stefan Seewald.
Yes, dear colleagues, I'm very happy to be here together with Rob. And before we start the examination, I want to say a great thank you to the team because you have a perfect organization here and a great team, so congratulations. And even we have now one of the last session. We have still very interesting case. And as you have seen, this is a patient with a dilated pancreatic duct. If we have such a patient, always we have the imaging, but first the symptoms of the patient are very important. And in this patient, it is interesting, patient has no abdominal pain, patient had pain in the back. That is the first point. She didn't have any weight loss, that's the second point. And we had a check of the laboratory results, and there everything was normal. She had no elevated lipase, she had no pancreatitis, and she only had a little bit, CA99 was a little bit elevated, was about 150. When we have now such a MRI image, we also have to look carefully to get more information out. And you saw very nicely in this area of this, where we didn't see any pancreatic duct, there was absolutely nothing. We had no really signs of compression that the duct was smaller. We didn't see the duct, and after some centimeters we had the dilated duct. That was another information, and that is a sign that there seems to be something more in the duct, not a compression from outside. And the second point, which is very interesting with regard to the image, that the bile duct was not dilated. So in such a situation, we for sure also think about pancreatic cancer, but I tell you this because we want to check first the papilla, because we can have theoretically a papillary tumor, or we can have something in the duct, for instance an IPMN. So the first what I'm doing now here is that we try to check the papilla. And sometimes for sure we can see the papilla with the duodenoscope, but we can also see it with the EUS scope, not always that good. And while I was talking, I lost the papilla here because we had it all the time when we were waiting for you very nicely. But I tried to find the papilla here with the EUS scope, and here is the papilla. So the papilla, I would say, looks a little bit swollen, but Rob said I sucked so much that it looks swollen. But I tried to deflate a little bit the air, because if this is a main duct IPMN, we would get already some mucus out of the papilla. And what I'm doing now is I always suck and try to get out some mucus. But even we have done this already now 5 minutes, we only saw some bile. So what I can say for the moment is it is not a papillary tumor. It is not a papillary adenoma, and we don't see any fishmouth papilla. So this is important information as a second step. Now we will try to use EUS to get more information. And this morning you have heard already from Rob very nicely, nobody can do this better, the explanation how to really describe the anatomy of the pancreas. So as he mentioned, and as we mentioned yesterday, we can try to start in the duodenum, or we tried in the cardia. So in this case, I will also try to start in the cardia. So I pull the scope back to the G junction. Now we switch for endoscopic ultrasound, and here we have the
Professor
aorta.
Seewald?
Yes.
Professor Seewald, sorry not to disturb you.
No problem.
I just want to go back to the papilla.
Okay, to the papilla, yes.
Just a clarification. There's no mucus coming out of the papilla
No,
as well.
we tried
No
5 minutes to
mucus.
suck air off, but there is no mucus. And second, the papilla looks a little bit swollen, but it's not a papillary tumor.
Okay, thank you very much.
Okay.
So,
Yeah.
but it does look a little bit, the term that we use is patulous. So sometimes there isn't just mucin exuding from the opening, but if it's patulous, sometimes you can milk some mucus out of it, which Stefan tried to do off camera. So I, in my own opinion, although the papilla is not pathognomonic for IPMN, it's certainly consistent also with it. There's no tumor, but there's a patulous opening.
Okay, so now we have found here the landmark of the aorta and the celiac, the takeoff of the celiac trunk. And now I release the big wheel a little bit, and I try to find, here you see very nicely the left adrenal. So this is the left kidney. And I torque the scope clockwise, a little bit back, sorry. And here. Now I see a structure of the pancreas. And what is here very impressive in this patient is that we see a dilated pancreatic duct here. That is the first. Maybe we can measure this. So if you are not sure, is this a vessel? We use Doppler for clarification. And now we will measure the pancreatic duct. So the duct is about 6 millimeters, so it is a clearly dilated pancreatic duct. So what I will try now, I first will have a look also clearly that I've seen clearly the pancreatic tail. And then we also have to mention that we have to focus now more on the texture of the pancreas.
Yes.
And somehow this doesn't look like a really normal pancreas. Usually we have this typical lobulation, but here somewhere parts of the pancreas appear a little bit more echo-poor, and then you have some echo-rich strands around. So I would say, what would you think? It looks a little bit edematous, or it is not really a regular pancreas?
Well, I think that while the parenchyma is not normal, it is also not atrophied. And this is one of the findings that we have. If the parenchyma is not atrophied and yet you have this markedly dilated duct, it suggests that something is expanding the duct from within as opposed to an obstruction down below. If this was a cancer in the head of the pancreas causing this much dilation, I think there would be almost no pancreas around it. So to me, although the pancreas doesn't look normal, it also doesn't look like either advanced chronic pancreatitis, and it also doesn't look like downstream obstruction. So I think so far this is consistent with IPMN in my view.
Yes. Okay, now what I'm going to do now is we are now in the area of the pancreatic tail, and now we trace the pancreas down into the direction of the pancreatic corpus, and for this I push the scope slightly in and I torque the scope counterclockwise.
Counterclockwise, yes.
So, and for sure I regulate a little bit the big wheel, and here we can nicely trace the dilated pancreatic duct down. So I push the scope in and I move very slightly to counterclockwise, and I release the big wheel. And you see I talk slowly, more and more counterclockwise. And sometimes we come into, this is a nice position here. Now this is the superior mesenteric vein. And this is a very nice position because on the right side we have pancreatic corpus and tail, and down here on 6 to 8 o'clock we can visualize the pancreatic head. And from this position sometimes we can also get the pancreatic duct and the bile duct in the longitudinal axis. But this is sometimes not so easy. Here in this case we can recognize pancreatic head, but I unfortunately cannot show you now the bile duct and the pancreatic duct in the longitudinal axis.
So sometimes from the stomach in a skinny person, you can trace the portal vein and the bile duct in parallel, with the bile duct being, the portal vein being on top and the bile duct being on the bottom.
Okay, but I think so far we have checked now pancreatic tail and corpus, and we can say there is no other tumor. We have a dilated duct, and now we try to go to the next landmark station. This is now duodenal bulb. So I push the scope in. Okay, then we switch to. Yeah, no problem. Okay, now we are here in the area of the pancreatic head, and we see very nicely here this dilated duct, but not only the dilated duct, there are also I would say side branches, or we can say cystic structures, but I think these are side branches. So what I'm doing now to get a better position, I push the scope a little bit in and I angulate the up and down wheel to get a better position. And sometimes here I push the scope in and pull it a little bit out. So now from the orientation we have on the right side, we have this is direction toward the ampulla, and on the left side we have the direction toward the pancreatic corpus and tail. So if we enter the duodenal bulb, we have different directions from the orientation to the pancreas. And this is very important also. We don't need the radial EOS for having a good anatomical overview. We can all do with the linear scope, but it is important now also that if we are on a specific level, that we torque the scope even counterclockwise or clockwise, until the pancreas completely disappears. And now you see my movement. I torque now the scope in the other direction until the pancreas here disappears on this level. So this is very important that we always have the movement of 180 degrees. When we do this, then we have seen the whole area of 360 degrees with the linear scope. And now I play a little bit with the small wheel, because sometimes we can get a better position. So I push the scope in and out. So the bile duct is not dilated.
Can you comment on the bile duct? Is it dilated or?
We can measure it, but I would say no. Maybe, yeah. Okay.
We may it may be a little bit compressed, Esperanza, at this point, but you know, it's
yeah. So patient still has the gallbladder, so it's still in the variation, I would say.
This is another view here,
Yeah.
but even out here, it's only 5 millimeters, so I don't think that there isn't any dilation. And there's a rule of thumb that that my partner Shyam Verderajulu taught me, and that is that if the pancreatic duct in the head is a greater diameter than the bile duct, that's a very significant sign for IPMN. So I think this patient has met that criteria.
Okay, so I think we would go for the puncture, and we heard a very nice presentation about needles, and we heard that the Procore needle gives us more material. So in this case, we also will use the Procore needle, and the advantage is now that we also have the Procore needle, a 25 gauge Procore needle available. Okay, so I introduce the needle, and as I said yesterday, the optimal position for moving the needle is the straight position. So first I check now the length of the needle. So we see here this needle, and now we have this adaptable sheath, and I fix it now, and now I try to get back to find our area of interest. Sometimes you should not wonder, because when you have introduced the needle, everything looks a little bit different. Okay, now here in this case, I have to bend the scope a little bit to have a close position, and now you see I am permanently on the suction to have a better contact. And now in the second step, I have already very much angulated the big wheel. I fix the big wheel, and mostly I also fix the small wheel. So this is the position I can have, and sometimes if somebody like Rob is available, he is so friendly to hold the scope. So now we see the blue dot where the needle will come out, and first we check now by color Doppler vessel interferences. So now, okay, I try to get the lesion almost in the center, a little bit on the left side, and now you see that we have a little bit the problem of the stability here, but I think we will see. So first I advance the needle. Now you see the tip of the needle. And now I think it's very important that we get here in the middle of this lesion. I don't like this. Okay, this is... Okay, now I'm advancing the needle, and now I'm here in this area.
Yes.
Okay. So usually we have to be careful, because the theory is when we have a dilated duct, we should not puncture the duct. And if it is necessary, then it's better when we do it in the perpendicular axis, that we, in case we have a leakage, that it is only a small area which can heal. So you see I'm here in the area of this mass, and now
It is soft?
It is soft, yes. We discussed about the fanning, is it correct? Yes.
Fanning?
Fanning, yes. So here in this case, because the lesion is very small, it's not so easy, but
Yes.
I try to go every area, and now I'm very careful not to go too much inside, because I can go in the area of the dilated pancreatic duct, and then we would have punctured the duct. So I think this lesion is almost only 1 centimeter. For this, I think
Stefan?
okay, yes.
Stefan?
Yes.
Sorry,
No problem.
we're going to.
Atypical columnar epithelial cells.
Kushima-sensei, you mentioned that atypical
Atypical with
columnar
epithelial cells with
epithelial cell.
clusters, many clusters, cell clusters, atypical cells. enlarged nucleoli and nucleus, round-shaped nuclei. We so. どうだろうこれアデノーマは well differentiated adenocarcinoma suspected. Oh, 難しいと思うんだこれ。マイトーシスないな。There is no mitosis. どうかね、温野さんどうかな、これ。
So I think this is the first important information. And we also not only smeared off the specimen, we also took into cytolite, and I think we can get some immunohistochemy and all these things, and I think then we have a more clearer diagnosis. But what we can say is there's something pre-malignant or malignant going on in this area, and I think the patient has to undergo surgery. That is one point. And the other point I also wanted to show you finally is we mentioned yesterday where is EOS good and where is EOS bad. So EOS is very good to detect the infiltration of the portal vein system. And I think what we can say here very clear is that this 1 centimeter lesion in the area of the pancreatic head has no connection to the portal vein system. And I think what we can say very clearly is that the patient is a candidate for surgery. There are no signs of vessel infiltration. What would you say, Rob?
Yeah, so Haru, it is very, very typical to get for these lesions to be very well differentiated. So the conundrum and the problems of the pathologist in sort of is this atypical? Is it well differentiated adenocarcinoma? For our immediate read, this would be a very typical. What I typically hear when I do this kind of a lesion. I think the second thing to note is that for IPMN, the part of the problem is that this may be a field deficit, so clearly there is disease in the head of the pancreas. The question is whether or not there's any high-grade dysplasia or early carcinoma in the other part of the duct. We did not see any ductal thickening in the body and tail, but certainly it will be a situation where I think they will resect the head of the pancreas, and then they'll need to look at the cut margin, and sometimes you end up getting high-grade dysplasia at the cut margin, and these patients sometimes end up getting a total pancreatectomy. So it's a difficult problem, but this is clearly an abnormal lesion, and I think if it's likely an early carcinoma, and it does look resectable to me.
So thank you very much, Rob's comment. And may I ask a pathologist, Kushima Sensei?
Yes. Let me get him the microphone.
Yes, yes. 串間先生、所見を日本語で構わないので教えていただけますか。
今お話があったように腫瘍であることは確かだと思います。 それで、その少しアデノーマにしては少し異形があるので、高分化ながんが否定できないというところだと思います。
Atypical cells and irregularity is seen.
串間先生、外科的な切除は必要だと思われますか？
Is surgical procedure required for this?
ちょっと外科的なことはよくわからないですけれど、今のお話で
切除が
必要だとおっしゃってたんじゃないでしょうか、先生方。
He was not very sure.
病理の方も先生、それでよろしゅうございますか？
腫瘍はあると思います。はい、腫瘍だと思います。
The pathologist agrees to
Neoplastic
perform surgery to this patient.
Yes, Rob. Stefan.
Yes.
Yes. Haru.
Kushima sensei mentioned that this is Kushima sensei mentioned, pathologist mentioned that this is definitely a neoplasia, at least.
Yeah.
So still we have some discussion of high-grade dysplasia or well-differentiated adenocarcinoma. But anyway, so pathologist agreed to a patient receives some excision of the tumor.
Yes.
Is it okay for your
Yes.
clinical point of view?
Yes. I think
Yeah.
that fits to
I
everything.
think it's very, very typical for them to have to go back and look at the tissue more carefully and do some staining and so forth. But my suspicion is, Haru, that this is a well-differentiated adenocarcinoma. I think it's converted to cancer is my thought. But I think either way, this patient will need to go to surgery, I believe.
And then you also mentioned that the proximal pancreas resection is not enough quite often in this kind of patient. So you recommend the total pancreectomy.
No.
no.
It may be okay. It's just when they do the resection margin, our surgeons will do a frozen section on the cut margin to make sure that there's no high-grade dysplasia at the cut margin.
But I think in this case here, we have only a 1 centimeter lesion, and the pancreatic duct also looked dilated, but there was nothing in the duct, nothing more. And I have hope here that the pancreatic head resection is enough. But when it is cancer, then we need finally Whipples. That all depends on the intraoperative evaluation.
Yeah.
Yeah, and from the ultrasonographic view, so main tumor is a 1 centimeter.
Yes.
And then the tumor has a clear margin,
Yes.
demarcated
Tumor has a
from the ultrasonographic view.
yes.
Yes.
And it is within the pancreatic duct.
Yes.
Okay.
Dr. Haas and Dr. Seewald, would there be any role for potentially pre-surgical or intraoperative pancreatoscopy to help delineate resection margins?
Yes, I think this is a very interesting point. We have heard a lot of spyglass technology. I had now the first case where my pancreatic surgeon called me in the OR. He did a surgical papillectomy, and I went with a spy scope in the pancreatic duct because this patient had a polyp in the pancreatic duct, and he wanted to know for sure if there is the resection is complete. I think this is a new field developing with new thin scopes we have.
In this case, we usually do pancreatoscopy when we do not know exactly where the lesion is. Now, statistically, it's almost always in the head, but we have found some that are in the tail. But it would be our usual practice to do that when there's diffuse ductal dilation without an obvious mass. In this case, you may not be able to get to the more upstream duct because of the blockage from this lesion. So I'm not sure that pancreatoscopy would help unless our tissue was suboptimal, and then maybe you could do some intraductal biopsies.
But now it is interoperatively, the surgeon on the open abdomen, we went in on the open abdomen. That's very easy then, because he has resected already the area, and then he shows us here is the upstream pancreatic duct, and we go in with a SPY scope.
Yeah, we could intraoperatively. You could certainly, after he's resected the head, you could do pancreatoscopy. Yes.
And that is really quick, you know. It doesn't take. It take only 30 minutes on the OR. It's not a complicated procedure.
Yes, thank you very much for
Well,
your comments.
thank you very much.